Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about any fetal condition that would warrant to get it investigated. So, meaning thereby that whenever we are doing the ultrasounds, especially the anomaly scan, so whenever we identify some sort of an abnormality to the fetus, whether it is a cardiac or a kidney or a gastrointestinal tract or kidneys and all those stuff. So probably the wholesome scenario for the patient and their relatives always remains can it be adjusted and can be looked around after the baby is born, or probably can we get away not doing those invasive testing to the baby and not to do the genetic testing. But we're going to talk about one condition which warrants that probably all the investigations should be done beforehand, before the baby is born, right? So one such condition is called as an echogenic kidneys, right? So we adjust the echogenicity of the kidneys with the liver, and then once we identify that these are echogenic, and then we try to see whether they're unilateral or bilateral, and then the conditions underlying etiology could be very many, and there could be between the structural to celopathy to obstructive, but the most important part would be the inborn error of metabolism, right? So once the baby is born, right, you imagine a situation in which the baby is there at 3 kg baby, and then once the baby, as soon as the umbilical cord is cut, and therefore the baby is all dependent upon his her own kidneys so as to filter out the blood and to exclude those metabolites through the body. So let us first see these slides, and then probably we'll talk about how do we manage all these conditions antenatally. This is the scan that we are doing at 20 weeks, right? And try to look around कि right kidney है, and then we are identifying कि इसका जो renal pelvis है वो थोड़ा सा dilated है और calyceal dilatation भी है. So major calyces are also dilated, and this is the left kidney. So what we are identifying कि both of the kidneys are really echogenic, right? So these are echogenic kidneys, and then we identify that this the corticomedullary differentiation जो है वो थोड़ा सा accentuate हो गया है या बढ़ गया है वो थोड़ा सा, और definitely the kidneys are echogenic, right? But the amniotic fluid is normal, and so meaning thereby that there are a lot of differential diagnosis that comes into our mind. Like first could be an ADPKD, which is called as an autosomal dominant polycystic kidney disease, right? So prenatal ADPKD might look like this, in which the kidneys are slightly bigger, and there can be normal amniotic fluid. And second is an ARPKD, coelopathies. Since we don't have the polydactyly, and therefore, so this could be ARPKD, ADPKD, and there will be nephronophthisis. We can have an obstructive uropathy, and we can have these genetic syndromes like Bardet-Biedl and Meckel-Gruber and short rib polydactyly, Beckwith-Wiedemann. But I'm more worried about these metabolic syndromes like so hyperoxaluria, cystiniurias, right? So that is how it is. So whenever we see these echogenic kidneys, by the face of it, we try to make a differential diagnosis. So ARPKDs are really very large kidneys, sort of an half an kg, and therefore, and the CMD or the corticomedullary differentiation is really very obscure, and the liger has gone down, right? So there is definitely oligohydramnios, so that makes an ARPKD. ADPKD, the kidneys are usually slightly bigger than the normal, but the amniotic fluid can be normal. And then we try to look around for the kidneys, both the parents, both the father and the mother, and they try to identify some sort of a renal cysts into the parental kidneys. And we've even identified that the mother could be the sort of an transmitting this mutation from the to the fetus, and therefore the de novo thing in an ADPKD usually comes from the mother. Secondly, we try to look around the polydactyly, so मतलब extra digit into the hands of the finger of the baby, so as to see that we see the Meckel-Gruber or we see the SRP, short polydactyly syndromes and all those stuff. But what we cannot identify is a nephronophthisis. What we cannot rule out is a renal functioning. What we cannot rule out is an inborn error of metabolism. So that could be Zellweger. We can have a Lowy syndrome, or we can have some uh, um, hyperoxaluria or a cystinuria that might manifest immediately after the baby is born, right? So there are two ways to see to it. Either we do the vesicocentesis, or we put the needle into the fetal bladder, and then we take out the fetal bladder and look around for the. So there are a lot of tests that we can do to fetal urine as well as the amniotic fluid. So genetic testing of the amniotic fluid and genetic markers to the baby is absolutely essential so as to identify what exactly that we are dealing up with, राइट एंड सिमिलरली आर द वेसिकोसेंटेसिस. तो बेबी के ब्लैडर से पेशाब लेके उसकी भी जांच कर सकते हैं और एमनियोटिक फ्लूइड की भी जेनेटिक की जांच कर सकते हैं. तो हम ये जानने की कोशिश कर सकते हैं बिफोर द बेबी इज बॉर्न कि क्या उसको कोई खराबी तो नहीं है. अगर कोई खराबी है तो हम उसको एंटीनेटली ही ये जानने की कोशिश कर सकते हैं what sort of an genetic condition that the baby might suffer or might entail when the baby is born. तो ये इमेजिन है सिचुएशन की 3 किलो का बेबी जब होता है तो आपके पास कोई इतना टाइम नहीं होता है कि आप कोई पेरिटोनियल डायलिसिस कर सकें, हीमोडायलिसिस कर सकें. फॉरगेट अबाउट गेटिंग अ रीनल ट्रांसप्लांट डन, राइट. सो एनीथिंग विच इज बाइलेटरल इकोजेनिक किडनीज एंड लीडिंग टू ऑल दीज थिंग्स. और जो लाइकर अभी ठीक दिख रहा है 20 हफ्ते पे, वो 28 हफ्ते पे ऐसा हो सकता है कि रीनल फंक्शन से डिटोरिएट हो जाए और जो ऑलिगोहाइड्रोमनस है या पानी की जो कमी है वो भी हमको मिल जाए 28 हफ्ते पे. So then that will also lead to some sort of an impediment to the growth of the baby, right? So this is one particular finding which is very very essentially, and it warrants that further evaluation of the baby should be done mandatorily, right? Thank you very much for your patience.